Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from SOBI.
This program is presented by Medscape Education Global.
Hello, I'm Cedric Hermans, head of the Division of Hematology at the Saint-Luc University Hospital in Brussels, Belgium. Welcome to this program entitled Is Normalizing Hemostasis an Achievable Goal in Hemophilia A? Joining me today is Robert Klamroth. Welcome, Robert. You are currently head of the Department of Internal Medicine at the Vivantes Hospital Friedrichshain in Berlin, Germany. In this activity, we will review the therapies currently available to manage Hemophilia A and the quickly evolving treatment goals for patients. We will then discuss the concept of normalizing hemostasis, what this means to both clinicians and patients, and whether normalization can be achieved with the therapies currently available. Robert, would you be able to start us off with an overview of the Hemophilia A and the therapies currently available for our patients?
Yeah, hi Cedric. Surely, it's a pleasure to be here with you and give some education about normalization in hemophilia A. So hemophilia is that we don't have enough factor VIII, and the disease severity is defined by factor levels and the clinical bleeding phenotype. And if you have no factor VIII at all, it's severe hemophilia, and it's moderate hemophilia up to 5% and mild hemophilia up to 30%. And all patients with low factor VIII can have severe bleeding symptoms, mainly in the joints and in the musculoskeletal system. And nowadays, we have a lot of different treatment options, and all started with the replacement of the missing clotting factor of factor VIII. And first, we have it from plasma-derived, then it was recombinant, then we modified factor VIII to extended half-life factor VIII, and now ultra-long half-life factor VIII available, which you inject only once weekly. We have bispecific antibodies which imitate factor VIIIa, and we have non-factor therapies that rebalance hemostasis, and shortly we had available a gene therapy for hemophilia A. And all these different treatments enable our patients to a better treatment and prophylaxis of bleeding. And I will focus a little bit on the bispecific antibodies because that is a new concept in the last decade, that factor VIIIa usually ensures interaction between factor IXi and factor X. And this bispecific antibody mimics this activated factor A. And the advantage is then you have a treatment which is subcutaneous with a long half-life, so you can administer it weekly, every 2 weeks or every 4 weeks. Factor VIII is still intravenous administration. The rebalancing agents like fitoseran and TFPI inhibitors inhibit the natural inhibitors of coagulation. And fitoseran reduce the production of antithrombin in the liver, and the TFPI antibodies lower the concentration of TFPI and enable thrombin generation.
And if I'm correct, all these agents do contribute to more thrombin generation.
All these agents contribute to more thrombin generation, and gene therapy, often the final goal in hereditary disease, was available for hemophilia A. Few patients were treated with a commercial product, and unfortunately, due to the low uptake, it will not be on the market anymore. So, Cedric, you see we have a lot of different treatments available. How would you say that our treatment goals for our patients with hemophilia have evolved over the last 10 years?
Well, that has been a revolution. Like you have been working in this field for many years, and clearly what we are doing today is fundamentally different from what we used to do 10, 20 years ago. And why is it like this? Well, all of you are more or less familiar with this classical conceptualization of hemophilia which is classified according to the clotting factor level that you can measure in the blood. As you said, we have patients with severe disease, less than one, patients with moderate mild disease, and then we have normal patients. And as you can see on this slide, there is a good correlation, or more or less good correlation, between the levels that we measure in the blood and the bleeding phenotype. What does that mean? It means that patients who do not have factor VIII at all in their blood, they will bleed a lot, on average once a week, in the absence of treatment. Moderate patients, most of them will bleed less, but although this slide looks nice, there is some discrepancy sometimes. We have some patients with moderate disease who still behave like severe patients. But that has been the classical classification, I would say, of hemophilia. And in the past, considering the treatment options that we had and that you reviewed with us, the short-acting factor VIII and the extended half-life factor VIII, well, at that time, the ambition for most of the patients was to convert severe into moderate. What does that mean? Trying to bring and keep factor VIII from below 1% to something above 1, 2, 3%. So that was the ambition. Why was it like this? Because let's be honest, you have had the same kind of experience. It's difficult by regular intravenous injection to maintain factor VIII constantly. We mean the trough level above 1, 2, 3%. But that has been the ambition for several decades. That was not really our intention, but that was imposed by the treatment that we had. Today, the ambition are totally different. And what we try to do is to convert our patient not from severe into moderate, but ideally from severe into mild and possibly normal. And this is something that we will discuss during this activity today. We want to increase this level of conversion. We want to bring our severe into mild, normal, and this is also the same for moderate patient. So
maybe you remember the PROPEL trial where we first tried to have a higher trough level of 10%, and it was possible with extended half-life factor A, but due to the infusions up to daily, patients do not comply with the regimen over a long time, and it was too cumbersome to reach this trough level. And that might be now different with the new products. What do you think?
yes, clear. Important to remind us this important trial that you conducted with a lot of success a few years ago. That was very important, showing that yes, it's possible to reach the mild range with the short-acting factor VIII and some long-acting factor VIII, but with very intensive treatment. And honestly, not all patients could do that, if I'm correct. So the treatment goals for all patients with hemophilia today are different. We want to have the majority of our patients ideally in a mild range, or if possible in a normal range. This is the expectation. This is our ambition today. And this is again illustrated on this slide, illustrating really what's the impact of the severity on the bleeding phenotype. If you have severe disease that is not treated, you are at risk of presenting with life-threatening bleeds. And clearly, if you are able to convert the patient into the severe or mild range, you see clearly the benefits. You will abolish the spontaneous bleed. If you are in a mild range, you could avoid the traumatic bleed. So that means, patients could now engage in physical activity. And if you are able to normalize coagulation, well, that has a major impact, and we will discuss this later on. That will impact our patient, not only physically, less bleed or no bleeds at all, because this is the ambition, but also a normal life mentally. So Robert, we have already addressed this concept of normalization, normal range. What does normalizing hemostasis in hemophilia mean in 2026?
So Cedric, we discussed already that we don't want to have any bleeds. We want to prevent any bleed in our patient. And you already told us that we need higher factor levels, or we have to go near normalization to reach this goal. And normalization in hemophilia is first, and we can discuss it further, normalization of the missing clotting factor. So factor VIII in the normal range is 50 to 150%, and we want to reach, with the replacement of factor VIII, more than 50%. That is the easiest way to explain it. But then at the second point, we want to normalize coagulation, and coagulation is more thrombin generation. So as a consequence of a normal factor VIII or any other treatment, we want to normalize thrombin generation. And as a consequence, it might be possible for our patients with normalization of coagulation that they live the life they choose, that we normalize their life physically and mentally. You all know that we normalize coagulation even with the old products, because in surgery we always did it. We normalized coagulation with a great effort, because a lot of IV injections were necessary to reach this goal. And now we talked about our perspective as physicians, but I think it's more important to talk about the perspective of the patient. And Cedric, what does normalization mean from a patient perspective?
I think it's important to emphasize that this concept of normalization is not that new. You have been involved in many trials of patients with hemophilia undergoing surgery, major invasive procedure, and in this patient, your goal has been to normalize coagulation. So, but clearly, normalizing coagulation during surgery is not exactly does not exactly mean normalization coagulation throughout life all the time at any moment. So this is, I think it's important to emphasize the fact that normalization is not a new concept. That is something that has been around and applied in our field for several decades. Also, maybe I'd like to emphasize the fact that this normalization, these definitions, they are to some extent complementary. They complement each other. They do not exclude each other. If they all go the same way, clotting factors, thrombin, and the life of the patient.
So again, we coming back to the patient now, Cedric. Does an improvement of treatment, did it change a lot for our patients?
I think it does change a lot. I think this is one of the most important change we have seen and witnessed over the last few years. Clearly, living without bleeds and with a minimal or reduced treatment burden and with factor levels or equivalent factor levels much higher completely change your life. That means that, the burden on your brain that you experience daily is minimized and in some patients abolished. Because let's be honest, for those of you who have regular interactions with patients with hemophilia, well, the brain, the mind of these patients is constantly busy, occupied by, the risk of bleed, the pain, mainly in the joints, the need to take the medication, the fear about treatment efficacy, the next injection timing, and also multiple implications and limitations. Think about your ability to travel, also the impact on the family, on your job, on your employer, on your colleagues at work, and also on your ability to engage in physical activity. So clearly, living with hemophilia is much more than bleeds. It's a lot of mental burden. And what we have seen is that with the new treatment and also the option that we have today to improve coagulation significantly, we are able to alleviate, to minimize this mental burden. And I think this is an important concept. And if I ask some of my patients, do you experience days in a week, in a month, where hemophilia is not occupying your brain, your mind constantly? Well, many of my patients will tell me, yes, Cedric, up to 5-6 days a week, up to 3 weeks a month. So this is a major impact. And we have seen this kind of slide many times. So this, you remember, Robert, this slide that our friend Mark Skinner generated a few years ago. And that was really an anticipation. That was an aspiration. He wanted to show that if we could improve coagulation, normalize hemostasis, that would result in health equity, but also in this mental liberation. So this is a beautiful slide, clearly illustrating what we are aiming at today in 2026. And on this slide, you can see also that, well, the joints of our patients have suffered in the past because the treatment were not efficient enough. Today, and green is a quite popular color today, we have much greener joints. And closely linked to this or correlated to this, the mental pressure has also been minimized, as illustrated on the slide with a green brain. So, and I think they are closely related. They are not isolated. Robert, in your mind, why should we promote normalization for our patients? And also another question, are we coming close to this normalization with the therapies currently available for our patients?
Yeah, Cedric, you already told about it. So we have the burden of the disease, hemophilia, bleeding in the joints, bleeding in general. And treatment can prevent bleeding and reduce the burden of the disease. On the other hand, we have the burden of treatment with a lot of IV injections. And you remember, then we started in thinking about normalization, we started in some patients with daily IV injections, with daily treatment of factor VIII to normalize factor VIII at least for a few hours during the day.
In a few patients.
Because the burden of treatment was far too high to achieve this for all patients. And I think our new treatment options now with ultra-long factor VIII or with the factor VIII mimetics or even with the rebalancing agents, you have the option now with a low burden of treatment to achieve a higher protection against bleeds and a better outcome in these patients. And you and your colleague were the first who said this kind of hemophilia-free mind, or to be free of the thinking of hemophilia during a week, a month. And I always thought only gene therapy can reach it. But gene therapy was not as successful as we expected in hemophilia A, and now we have a lot of other new treatments where we might reach this goal even easier with this continuous treatment and free the mental burden of our treatments.
And maybe if I can comment this slide, I think it's important if I can comment this slide, you need to look carefully, because it does integrate, you represent a lot of information. It's clear that with the new treatment, yes, the brain, the minds used to be red, and now you see that it's getting greener because, this liberation, although this liberation is not always complete, full liberation. Let's be honest, there might be a lot of variability, and we'll come back to that. But I would invite our colleagues to carefully look at, what each of these icons represent, because I think they nicely integrate the multiple impact of the treatment on the mental liberation of our patient.
Yeah, and I think, Cedric, that's important for the clinician because patients are different. Patients have different ambitions and different treatment goals. And I think the modern concept of hemophilia treatment now is that you have a shared decision making about the treatment. Because if you have a shared decision where the concept is attractive for the patient, then adherence to treatment is much better. And now we are, for the first time, have the possibility to choose between treatments and find the correct individual treatment for our patients. What do you think?
Well, yes, you're totally right. I remember 15, 20 years ago, well, we were already good friends at that time. Well, clearly the only option that we had was to make a selection between two different types of factor VIII, with no fundamental difference. Today we have a much broader today we have multiple treatment options that are all different. I wouldn't say that one is superior, but they all have their strengths and limitations, but all of them have the ability at least to meet the expectations and needs of every of our patient. But that means that what we are doing in our clinic today is totally different. We need to try to identify at the individual level where are these needs and what are these needs and these expectations. So it's totally different from what we used to do. It's clear that some patients are better candidates for ultra-long high sustained activity factor VIII or bispecific antibodies or possibly gene therapy when it will again be available. This is clear. So, Robert, can patients who are currently receiving prophylaxis with factor VIII replacement therapies experience normalized hemostasis? So is this aspiration now a reality? And how does the factor level that are achieved in these patients impact on this?
I think with factor VIII now we can reach normalization at least for a certain time in our patients. And especially the extended half-life products and the ultra-long half-life factor VIII, where we can measure factor VIII, you can see that normalization is now reality in some patients. And if you look now, looking back for our different treatment options, with standard half-life and extended half-life, normalization was difficult because the IV injections were very often during a day. And now with ultra-long half-life factor 8, we can at least, if we dose it once weekly, be 4 days in the normal range. And that's a big difference from my point of view. And if we look in the future, there might be even other options to normalize hemostasis. But at the moment, the concept of normalization, if we go back to the beginning, is we normalize factor 8. With a normalized factor 8, we normalize thrombin generation, and that results in a normalization of hemostasis, which is possible with extended half-life and much easier with ultra-long half-life factor 8. What do you think, Cedric?
Well, I think the data and the graphs on this slide, I think that the data on this slide are really fascinating. They really represent what we have been expecting for a long time. When you see the decay curve for factor 8, it's totally different behavior. So clearly, we need to realize that patients will spend several days above 40%, and that has multiple implications. And after a whole week, the level is 15%, so in the mild range. And if you compare this with the products that were available in the past, I think it's a dramatic change. And recently, with some colleagues, we worked on this because we wanted to differentiate, and we showed nicely that maybe a nice way to differentiate the product is to look at the area under the curve, especially the area under the curve, so the surface above this curve that you spent above 40%. And well, you don't need to be a skilled statistician here or pharmacokinetic experts to notice that there is a significant difference. There is a difference in the levels, there is a difference in the kinetics, but that also does translate in a major impact on the life of our patients.
Yeah.
So I think this is very important to realize.
So it's still an intravenous product, but it changed a lot for our patients who are still using factor 8. Cedric, there are a lot of patients who are using non-factor replacement therapies. What do you think? Is there enough thrombin generation with the existing products to achieve normal hemostasis with these products too?
Well, this ultra-long high sustained activity factor 8 is certainly a major advance, but still it needs to be given intravenously. And let's be honest, not everyone is able to do that. There are some patients, in spite of my efforts, your nurse efforts, your initiative, and the whole mobilization of the community, we are not able to achieve this. So, we have alternative non-replacement subcut therapies, but I think we need to look closely at what they help us to achieve in 2020. Well, today, what they help us to achieve. So for the moment, we have a single bispecific antibodies widely commercially available. Other agents are currently being developed, but that bispecific antibody helps to mimic factor 8 and will keep this equivalent factor 8 activity in a range around 15% most of the time. So this is not normalization on one side, and in the other side, it's a little bit rigid. So there is no way to increase it. So it will remain. And because of this, you will still need factor 8, exogenous factor 8. Some people say it's adjunctive factor 8 in case of trauma, accident, bleed, operation. And for gene therapy, yes, you have a lot of experience in gene therapy of hemophilia A, but unfortunately, there is no currently any commercial agent available. But from the experience that has been gathered over the last 10 years, we know that, yes, some patients treated with gene therapy could benefit from a normalization of their coagulation. But again, it's nice, and this is also your experience, that was not predictable. Some patients were lucky enough to achieve this and keep levels in the normal or close to normal range for a prolonged period of time, but that was not systematic for all our patients. So there is a lot of variability there. So let's hope that gene therapy for hemophilia A will be improved, will come back. But I think there are still some differences. And we also need to emphasize that next generation bispecific are currently being developed to help reach hemostatic activities higher than what's currently achieved with the agents that we have. And also there is another aspect that we should look at maybe. So we discussed about the levels, we discussed about the thrombin generation, about the impact on life. But let's be honest, when we treat our patient, what we want to achieve, and to secure is the formation of good clots. And well, there might be some differences here. So I will not go into the details, but if you compare a clot that has been generated following treatment, classical replacement with factor VIII on the left, and a bispecific antibody, there are some differences. So difference in terms of the thickness of the fibers, maybe the density of the fibrin network, maybe its strengths, its response to fibrinolysis. So I think this is also something we should look at. So what do you think about this concept of looking at the clot and the structure of the clot?
I think there are still a lot of open questions, and we know for a long time that the clot structure is thrombin dependent. And normalizing thrombin leads to a normal clot. And so far, the mimetics were not able to normalize thrombin generation completely. So it's a clot, but how far it's normal or not normal, that's very difficult to distinguish. And I think we have to have a look on this in the future.
A question to you, and a question I think for both of us. And I think it's an important topic to discuss. Can normalization be achieved for all patients with hemophilia A, either now or in the future? So what's your take on this?
I think we can normalize coagulation. If we first stay with coagulation, yes, we can normalize coagulation. We can do it now with factor VIII, and we can do it in the future, I'm quite sure, with factor VIII amimetics too. If you can normalize life if you have a chronic disease, that is a different question and needs to be seen how successful the modern treatments will be.
Yeah, I share the same opinion that especially with the high sustained activity, ultra long factor VIII, yes, it's clearly possible to normalize and also to quantify, to measure this normalization. So because you can measure factor VIII and you can share with your patients the data, clearly demonstrating without any ambiguity that factor VIII is in the normal range. Clearly that will last for a few days, and then at the end of 1 week it will be 15. Although, do you have any practice of sometimes, in patients who really want to have a normal factor VIII throughout the week? Is there any option to achieve this?
We are very keen to evaluate patients about chronic synovitis. And the German guidelines recommend a factor VIII level above 30% in case of proven chronic synovitis. And in these patients, we are using higher doses of factor VIII to achieve normalization throughout the whole week, and that usually results in the application of ultra-long half-life factor VIII 2 times a week.
Yeah, so this is something possible, but again, you need patients who have the motivation, the venous access, and who also understand the rationale for doing this. But I can report the same kind of experience. I also have patients who are now on 2 injections per week. Yes, there is a burden, but at the same time, there is this major benefit of having normalized factor VIII throughout the week, which is a major advance. And yes, I agree also that with bispecific antibodies, well, the agent that we now have, emicizumab, it was a major advance, but now we understand better how these agents work, especially we know how we could improve their affinity, binding to factor IX, factor X, and I think there are several pathways now to improve their potential to generate more thrombin. So a lot of work is going on there, and yes, I think that should be the ambition for most of the patients. So I think it was a great topic, a lot of enthusiasm. Certainly, we try to re-explore the past, but certainly we shared with you a lot of aspiration and ambition. Although we are not yet there, there is no yet normalization for every patient, but we are on that way, and I'm sure that all together we will achieve this in the future. So, my dear friend Robert, it was great to have you here, and thank you for your great insight, the discussion as always, and thank you to all of you for participating in this activity. Please continue on to answer the question that follow and complete the evaluation. This is important for us to shape future activities. Thank you.
This program was presented by Medscape Education Global.